Tonight's talk is about modern treatments for varicose veins, and this is the current state of progress in 2017. Now, a little bit about me. I'm a vascular surgeon. I trained in London as a doctor at King's College Hospital and did my surgical training at King's College, St Thomas's and St George's. And I've been a consultant in the NHS for approximately 13 years. And then subsequently I went into private practice in 2007. That's 10 years ago. And for the last 10 years I've been treating patients with venous problems exclusively in my facility in Dorset. And we've established a clinic which essentially does nothing else but treat people with varicose veins and the problems that arise from lower leg venous problems. Now, another important part of the team is Mrs. English. Ros English has been the manager of the team, of the clinic, since 2002, and she has been instrumental and fundamental in assembling the team that we have now that are able to do the work that we do. We do all of our treatments under local anaesthetic in an outpatient facility, and it's on a walk-in, walk-out basis using the latest treatments. Now, it's not all about me and Ros. We're also supported by a team of nurses, administrative staff, and there's a picture there of the team, and on the far right is myself and my wife, who are the directors of the clinic. Behind the scenes, not shown in this photograph, is the medical advisory committee made up of 7 members who look at all the quality structures, the governance, the practice privileges, and they review what we're doing to make sure that we're quality assured at every stage. The newest member of the team, who's sitting behind you, is Lisa and Leah. Lisa has taken over as the administrative secretary and office administrator, and Leah is helping us on a consultancy basis with compliance with the CQC, which has been likened a little bit like Ofsted for hospitals and clinics. Now, you're aware that venous disease is important and common. In fact, venous disease is very common. This is a study called the BOND study. It's the most thorough and rigorous study that we currently have, and it looked at over 3,000, nearly 4,000 people, both clinically, looking at their legs very carefully, taking a questionnaire about their leg symptoms, and also doing an ultrasound scan of their legs. This was for people between the ages of 18 and 80. And in accordance with the International Classification of Venous Disease, people were categorized into one of 6 categories. C0 being their legs are perfectly normal and we can't find anything abnormal on ultrasound. And the most severe form of disease is C5 and C6, which is varicose eczema and leg ulcers. Now, the striking thing to me is that barely 10% of the population had what could be classified as a completely normal leg. And it also shows that almost 1% of the population will either have or have had a leg ulcer at some stage in their lifetime. And C0 to C6 is a progression. Venous disease is progressive, it doesn't get better of its own accord, and with time somebody will progress from C0 to C2, C3, varicose veins, leg swelling, varicose eczema, etc. So there are very few people in their 20s with varicose veins, C2, but there are many people in their 80s who've got C2, C3, etc. So it's a progressive disease that tends to get worse with time. And the other striking thing is that when they looked very carefully at this group of nearly 4,000 people and they did an ultrasound scan, barely 2/3, nearly a third had some abnormality on their duplex scan, over a third in fact. So it's very common disease that's progressive. And to give you some idea of its importance, we spend in the NHS nearly £1 billion treating leg ulcers. The complications of venous disease such as phlebitis and leg swelling and varicose eczema cause a lot of time off work. They cause a lot of suffering and misery to the people involved. So it's a really big problem. So what is the underlying problem? Well, the problem is called reflux. Now, some of you may be familiar with esophageal reflux or indigestion. This is when acid leaves the stomach and travels up in the wrong direction. Well, the similar problem can occur in the veins. The purpose of the veins is to carry blood from the foot back to the heart, up the leg, and it does that by the action of valves which keep blood flowing in the right direction. One-way valves that work to promote flow up but prevent flow down. Now, if blood is allowed to flow down from the top of the thigh when you stand up, so if you were to get out of bed first thing and stand up, and you have faulty valves in these superficial veins, blood can flow down in the wrong direction, superficial venous reflux. It can fill the surface veins, causing lumpy varicose veins to appear, and it can also give rise to spider veins, ache, throbbing, swelling, and if it's very prolonged and very severe, it will give rise to varicose eczema and leg ulcers. I don't want to get too technical, but I want you to remember that the fundamental problem is an abnormality of the valves and reflux, flow of blood in the veins in the wrong direction. That is by far the commonest problem with the veins. So how do we diagnose this problem and how do we assess it? Well, we do it with ultrasound. Now, at our clinic, everybody who has a venous problem is assessed by what's called a venous duplex ultrasound scan. It's performed with the person standing. It's a complete scan of the leg from the top of the thigh down to below the knee and towards the ankle, looking at the superficial veins, the deep veins, and it's looking at the action of the valves and the direction of flow in the blood in the veins, of the blood in the veins. And we're looking to see if there are any obstructions or any abnormal directions of flow. And as you can see on that picture on the right, we can actually see the valves, and in real time we can see them opening and closing, and by applying a Doppler to the ultrasound we can actually see whether the flow is upwards or downwards, and we can map out the flow of blood in the leg veins. So we can be very precise about what's causing the underlying problem. So what are the complications of veins? Well, apart from being unsightly and apart from causing ache and throbbing and swelling, a lot of symptoms, they can give rise to quite serious problems. One is phlebitis. Phlebitis is thought to be a trivial problem, but we'll come on later and see that it's actually quite serious. Varicose eczema, a late complication of veins, which is the precursor of a leg ulcer. Varicose veins and reflux are a risk factor for deep vein thrombosis, and they can also cause deep vein thrombosis where other risk factors are operating. And of course, venous disease is the commonest cause of leg ulceration. So I'm briefly going to cover these. Phlebitis used to be thought to be a trivial thing. It used to be something that you would be dismissed about. You would be told to take some aspirin or put some ibuprofen cream on. But we now know, using ultrasound, that phlebitis is always accompanied by some degree of clot formation in the superficial veins. And that clot formation can extend and propagate into the deep veins. In fact, it's an important association for the development of deep vein thrombosis. And now we would always recommend that anyone who is suspected of having phlebitis has a duplex ultrasound scan. Sometimes the diagnosis of phlebitis can be difficult. Sometimes it's confused with infection. Sometimes it's confused with cellulitis or an allergic reaction. The only precise way to diagnose phlebitis is with a duplex ultrasound scan. And using a duplex ultrasound scan, we can determine if there's a risk of imminent deep vein thrombosis, and we can also establish whether a deep vein thrombosis has in fact already occurred. So it's mandatory now in suspected cases of phlebitis to have an ultrasound scan. Varicose eczema. Now this must be one of the most confusing terms ever, really. Varicose eczema gives the impression that this is a skin condition, that it ought to be treated by dermatologists, and the treatment is likely to be a cream. In fact, none of those is true, and none of those is appropriate. Varicose eczema is in fact a vascular condition, and the underlying problem is usually reflux. So it's a vascular problem and not a skin problem. The reaction of the skin is a result of repeated injury and inflammation. And the skin has a very limited number of ways of responding to inflammation and repeated injury. It'll look red, it'll be itchy, it'll flake and scab. It looks like a primary skin problem, but it's not. It's a vascular problem. And the real significance of varicose eczema is that if not treated appropriately, it is a precursor to a leg ulcer. So it's a warning sign that a leg ulcer is imminent. And it's really regrettable, unfortunately, that so many people with varicose eczema are neglected and allowed to develop a leg ulcer. Now, deep vein thrombosis, there are many causes of deep vein thrombosis. The commonest reason for a deep vein thrombosis is actually admission to hospital. But varicose veins are a risk factor. They're not really the cause, but they're an important risk factor. So in combination with another risk factor, such as going into hospital, going on a long flight, or if there's a phlebitis in the veins, all of these are associated with an increased risk of DVT. And then finally, the most feared complication of veins is a leg ulcer. Now this picture shows a series of varicose veins. There's discoloration of the skin in the mid-calf, which is varicose eczema, and then again around the ankle there's more varicose eczema, and right in the middle there is a small leg ulcer. And this is a patient we treated at our clinic a couple of years ago, I think, who came to see us, and we successfully treated her reflux, the underlying issue, and we've subsequently cured the ulcer and got rid of it, and I'll show you a picture of that later. So, that's a quick survey of varicose veins, the complications, the consequences, the underlying problem, which is reflux, and I'm just briefly going to touch on some advice from the National Institute of Health and Care Excellence, and then we'll talk about what we can do about it all. NICE in 2013 came out with some key recommendations about the treatment of varicose veins, and among them were that everyone with varicose veins and symptoms should be referred to a vascular team, a team that can carry out a duplex ultrasound scan, and a team who have the necessary skills and expertise to carry out their recommendations for treatment. NICE has suggested that everyone with symptomatic varicose veins be treated by an endothermal treatment, by which I mean the veins are treated with catheters inside the refluxing segment using heat energy to close the vein, and I'll come on and speak about that in a moment. But NICE have approved endothermal treatments as the #1 choice for varicose vein treatment and superficial venous reflux. They've also said that #2 choice is ultrasound guided foam sclerotherapy, and we can talk about that in a moment. And surgery has been relegated to a distant third. So it's no longer the case that people should go into hospital and have surgical stripping anymore. And in fact, all the treatments that we do are under local anaesthetic on a walk-in, walk-out basis. They're endovenous, by which I mean we treat the vein from the inside, either using catheters, which deliver heat energy, or we treat the vein with sclerotherapy, which is injecting the vein with a prescription medicine which is designed to gently remove the delicate lining of the vein, called the endothelium, and then start a healing process within the vein, causing the veins to shrink and shrivel and disperse. And at our clinic, those are pretty much exclusively the two treatments that we use. We think that endothermal treatments and ultrasound-guided foam sclerotherapy in selected people, based on the ultrasound, are roughly equivalent. We think the results are very good for both, and when we come to discuss the pros and cons with you in detail, we discuss with you what your priorities are, and also there's the consideration of how much does it cost, and we can come to a decision together about what might be most appropriate for you. But those are the two treatments we do exclusively. We change the sclerosant solution, the prescription medicine, into foam, and we inject that under the guidance of ultrasound so that the unhealthy veins that are refluxing are treated by injection on a walk-in, walk-out basis. So, this is how we do it. All the treatments that we do are done through little pinpricks in the skin. They're all guided by ultrasound, and we can introduce either fine catheters or fine needles under local anaesthetic, deliver heat energy to the inside of the vein, or deliver prescription medicines to the refluxing veins with unhealthy valves. Because we do it under local anaesthetic, there's no risk of general anaesthesia, so they're very safe. Because we don't make any major cuts on the legs, there's virtually no scarring, there's very little discomfort afterwards. We haven't seen at our clinic any serious infections. We haven't seen any infections for years. Deep vein thrombosis is extremely rare. I think when we looked at the last 5 years, we've treated 1,000 people and we've had 1 deep vein thrombosis. And that wasn't a serious deep vein thrombosis. It was picked up early, and with a short course of blood thinning injections, it went away. So these are very safe treatments, they can be done on a walk-in, walk-out basis. You can get back to normal activities, driving, work, social activities very quickly. This is a picture of our treatment room where we carry out the procedures. You can see that I'm performing the catheter treatment. I've got the ultrasound on the outside of the leg, watching the position of the catheter, or it might be where the foam sclerosant is being injected. It's being watched by ultrasound on the outside. There's a nurse there in front of me who is monitoring the patient, looking after the patient, making sure that the observations are fine, that the patient's comfortable, and if there's anything the patient wants to bring to our attention, I'm alerted, because I'm concentrating on the screen and I might not be paying attention to the patient. To my right, there's a nurse who is assisting me, who's scrubbed, and who's helping me with the procedure. So there's 3 people plus the patient in the treatment room. And just to give you an idea of what it looks like on the screen, it's a little bit technical, but what you can see there is the catheter. It's inside the vein, which is the dark tubular structure running from the lower left quadrant of the picture up towards the right, and we can see a little tributary. But that's the sort of image we get. We can be very precise about where the catheters are inside the vein, where the sclerosant is being injected, and we can deliver the treatment to exactly the correct position inside the unhealthy vein. And just to show you, it looks a little bit scary, but just to show you 3 pictures that are all taken at roughly the same time. We've got me doing the procedure on the leg through a little pinprick. We've got the catheter shown on the ultrasound, demonstrating that the procedure is going along very nicely. And then we've got a member of our staff chatting away to the patient who is comfortable, being monitored, pulse, blood pressure and so forth, and being kept informed about what's going on. So we're confident that we're doing the right thing for the person and that they're comfortable in knowing what's going on. We work with some very nervous people, and we specialize in nervous people. I've had this procedure done myself, and I can tell you, although I know everything that goes on, I was a little bit nervous myself. So I appreciate the the things that the nurses do to keep me reassured and keep me comfortable. So let's turn to NICE, National Institute for Health and Care Excellence. NICE in 2014 produced some quality standards, and we looked back through our last 7 years, and we have demonstrated that we were actually meeting those quality standards in 2010, when this advice was actually produced in 2014. So we're not bragging, but we'd like to think that we were among the first to adopt this new treatment. It was nothing new in 2010. In fact, this treatment had just come out in 1999. I was the first surgeon in the Southwest to do endothermal treatments for veins, and I adopted that in 2002. It wasn't experimental at that stage. There was sufficient information to show that it was safe, reliable, and effective, and that was the time that I adopted it. I and the members of the clinic were the first to adopt ultrasound-guided foam sclerotherapy in the Southwest. We weren't the first. It was a surgeon called Juan Cabrera in Spain who invented ultrasound-guided foam sclerotherapy. But when it became clear that it was safe, that it was effective, and it was an alternative to surgical stripping, we were the first to adopt it in 2005. That's where we are at the moment now. We are using endothermal treatments. We are using ultrasound-guided foam sclerotherapy to treat reflux, the underlying problem, the varicose veins, and to alleviate the problems and complications of veins. We are following, in fact we were following NICE guidance before it was published, and we continue to follow it, and we're meeting their quality standards. So what can you expect from treatment? Well, I've got a series of slides now coming up, and they show the sorts of things that sort of people we treat, the sort of leg problems they have, and I'll show you their before and after photographs. These photographs are provided with the expressed permission of the patients. They've written expressly to say that we can present them at these meetings. The picture on the left is before, and the picture on the right is between 6 and 12 weeks afterwards. It's around 8 weeks, sometimes a bit earlier, sometimes a bit later. But the left is before and the left is after. This is a lady who had varicose veins in both legs. The first picture on the left shows the inner part of her thigh, and she's got varicose veins in her thigh and calf. And the picture on the right shows the result 8 weeks later. This might show a bit better. This is the same person with lumpy varicose veins at the backs of her thighs. And she had both legs treated in one visit under local anaesthetic, dealing with the reflux and the knobbly varicose veins on a walk-in, walk-out basis. If you go to our website, she's actually been very kind. She was so pleased with the results that she did a video testimonial, so you can watch her talking about her veins, and you can see the pictures on the website. It's not only women who get varicose veins, we men get them as well. In fact, most of the epidemiological studies suggest that varicose veins are just as common in men as in women. But like many things, women are more likely to access healthcare than us men. But this is a gentleman who had quite bad varicose veins in his left leg. You can see the picture at the back, and the picture on the right shows endothermal ablation and treatment of the varicose veins, and that's 8 weeks later. This gentleman I remember well. He worked in cabin crew for one of the big airlines. I can't remember which one, but he had a knobbly vein at the big bulbous vein, very superficial under the skin at the back of his calf, and he was concerned that he might knock it on a flight. He had injured it a few times, and that it might cause a problem. So during a short period of time, he wanted to have his veins treated. We treated him with endothermal ablation and treatment to the varicose vein, and that's the result 8 weeks later. And these must be the worst veins I've seen for a long time. They're typically in a man. Men tend to come later than women when their veins are very severe and causing a lot of symptoms. And he too had both legs treated in one visit by endothermal treatment and treatment to the lumpy varicose veins. And that's the result 8 weeks later. So, spider veins. Spider veins are often associated with reflux. They're not always simply confined to the skin. We tend to find that the majority of people have reflux demonstrated on an ultrasound scan, and it's important to identify whether there's reflux or not, because if there is reflux and it's the cause of the spider veins, these micro-injection treatments are ineffective. Indeed, they may actually make things worse. So people have to be correctly identified as having no reflux or having reflux and then treated appropriately. If they've got no reflux, they can go on and have their micro-injections, should they wish. But if they've got reflux, then we have to have a discussion about whether it's appropriate to treat the reflux and then go on to have micro-injections. So a duplex scan is important even for what appears to be a relatively trivial thing. Now, surprisingly, the knobbly veins we can deal with quite easily, often in one visit, and at 8 weeks we get very good results. For spider veins, there's often a course of treatment that's required. It's rather perverse, but the smaller the vein and the closer it is to the skin, the more difficult it is to treat. These veins are actually in the skin and part of the skin. They can't be surgically removed. They can't be treated with endothermal treatments. And you've got to treat the skin very gently. So what we do is, using a very fine needle, often with magnification, we will put a very mild solution of sclerosant directly into the vein. Now the appearance is that it disappears. Of course, that's only because the blood within the vein is being displaced by a clear, colourless sclerosant solution, prescription medicine. So temporarily, it looks as if it's disappeared. Doctors give it the rather fancy term of blanching, but that indicates a successful injection. The injection removes the delicate lining of the vein hasn't in fact gone, and the vein then responds over the course of several weeks by shriveling and shrinking. Often 3 treatment sessions are required with an interval of about 3 months, so it takes about a year to get an improvement. So although the photographs previously are showing you the difference in 8 weeks, this is the difference in 18 months. And as you can see, it's much improved, but it's not perfect. Unfortunately, there isn't a perfect treatment for spider veins. Sclerotherapy, micro-injections are the best we have available, but they're not perfect. We also at our clinic, this may not be of relevance to you, but we also treat hand veins. One of the things that happens as we get older is the veins on our hands look bigger. They're not unhealthy, they're not diseased in any way, they don't require a duplex scan. But obviously for some people they look very distressing and very unsightly, and we can treat those with a mild sclerosant solution to get them to shrink, and we can also restore some of the volume on the back of the hand. Another reason our hand veins look more prominent as we get older is because we unfortunately lose tissue on the backs of our hands. We lose volume and elasticity, and we can inject around the vein, again, a prescription medicine which will stimulate the natural regeneration of collagen. Just to give you an update, that poor lady who had an active ulcer and varicose eczema and a lot of varicose veins, we treated her with endothermal treatment and foam sclerotherapy, and her ulcer was healed. The varicose eczema was largely improved, and her leg symptomatically was much, much better, and her risks of getting another ulcer or the ulcer deteriorating were greatly diminished. Now, as I've said, varicose eczema is a bit of a misnomer. It must be one of the most misunderstood terms. You can't cure varicose eczema. It's a reaction of the skin to inflammation and damage. Sometimes, if it's neglected, the skin will be damaged beyond repair. We can remove the reflux, we can remove the downflow, we can remove the source of inflammation. But if there has been damage to the skin over a long period of time, although the body will try to regenerate and try to heal, some of the damage may be beyond repair. So I have treated many people at an early stage, and the varicose eczema goes, it disappears. That means the damage was not irreparable, and over the course of many months and years, the skin can return to near normal. However, usually by the time I see people, there has been quite a lot of irreparable damage, and although we can cure the ulcer and we can take away the source of the problem, the skin never returns fully to normal. It's always perhaps a little vulnerable to any injury and might re-ulcerate. But at present, prompt treatment using endothermal treatments and eradicating the reflux gives you your best chance of curing the ulcer quickly and reducing the risks of recurrence. So, in summary, ladies and gentlemen, venous disease is common and it causes significant health problems. So we call it morbidity, you might call it suffering. It does cause a lot of misery. It's unsightly, it aches, it causes a lot of symptoms, it can cause complications, time off work and pain. Deep vein thrombosis is an important cause of death. In fact, it's the second commonest cause of death after heart attack. So these are not trivial problems. I agree with NICE. Venous disease should be treated by a specialist team, and I think everyone with venous disease who is suitable for treatment should have a duplex scan, and they should have the two main treatments, endothermal treatments, which we've discussed very briefly, or ultrasound guided foam sclerotherapy. And we think that duplex is important both before, during and after the treatment, both to assess what is wrong, to confirm that what we're doing actually during the procedure is correct, and then thereafter to have a scan to confirm that what we set out to do has in fact been done and we've reached a successful conclusion to the treatment. Modern treatments, as of 2017, don't need to involve general anaesthetic. They don't in fact need to be performed in a hospital environment. I would say they don't even need to be done in a day case facility. I think they can be very safely performed in a clinic, outpatient type facility. And I think, in fact, local anaesthetic is the treatment of choice. It's much safer than general anaesthesia. It has none of the risks associated with general anaesthesia. And I think actually performing it under local anaesthetic means that we can confirm that you're moving, that the blood is flowing through your leg, and you haven't got these long periods of immobility and unconsciousness which render you liable to the most dreaded complication, which is deep vein thrombosis.